Hello, everybody. I'm Dr. Al Heuer here. I am Terry's partner in A&T Lectures. I also teach at Rutgers School of Health Professions. I do some other stuff, though. I still do patient care and edit some textbooks. So this particular lecture is looking at current practices in nicotine cessation, okay? The title is about 90% accurate in that it really talks to nicotine in terms of smoking, also in terms of vaping. But we're also aware, particularly when we talk about vaping, not all of vaping involves nicotine-containing substances, but the bulk of it does. Okay, so we're really going to drill down on that a bit here. So let's look at some of the actual learning objectives. We're going to review the epidemiology, fancy word, and statistics regarding smoking and nicotine dependence. So epidemiology is just the patterns that are out there. Is what is the frequency, what percentage of the population vapes and smokes and things along those lines, and some of the with that, what are some of the effects of that smoking and vaping in those populations. So that's really, when we talk about epidemiology, that's what we mean. Review some of the information on vaping and e-cigarettes, identify new smoking and nicotine dependence treatment quality measures, newer, they've been around for a little bit, for accreditation and reimbursement. Assess the smoker's readiness for a quit attempt, stage of change. Differentiate between or amongst the different types of smokers, whether it's a physical dependence primarily or a behavioral user. Most of the time, and it does involve a physical dependence, and many times there's both components to it. There's both a physical dependence as well as a behavioral aspect of it as well. Advise smokers and nicotine users on first-line medications for nicotine dependency, and to provide you guys with additional resources should you want to drill down and learn more about it. So types of dependence or types of substances that are out there, cigarettes, vaping devices, e-cigarettes are not exactly the same thing, but there's actually vaping devices that look like cigarettes. And then there's also vaping devices that look nothing like cigarettes at all. Electronic nicotine delivery systems are also referred to as heavy cigar and pipe smokers. And then smokeless tobacco as well. We're really not covering that to a large extent, but it can also represent a form of nicotine dependence. So a word or two or three or four about vaping and e-cigarettes. So it involves a heated liquid, thus creating fewer hazardous particles that can be inhaled. So fewer, that's really the key there. Just if I say nothing else about this slide, I do not mean to infer that vaping and e-cigarettes are safe. It's not the purpose of this at all. In fact, a lot of the comparison, particularly where they talk about vaping and e-cigarettes, that side of the equation is still being investigated. So it's not fully understood. I really want to say that. However, what we do understand is what I was saying, that heated liquid, fewer hazardous particles, mostly propylene glycol and glycerin. Okay. Different flavorings and preservatives. Nicotine is often added. The flavorings have been added. There's restrictions on the flavorings that have been presented to try to address an explosion in the adolescent individuals that use vaping devices. I'm not saying it's been effective in doing it, but they're doing different things to recognize that adolescents are really using these devices at, second bullet here, an exploding rate or exploding popularity over the past 5 to 7 years. The newness means that these longitudinal studies about the health dangers are still in the future. When we talk about longitudinal studies, let me be clear. Some of the other presentations that Terry and I give, we talk about cohort studies, where we actually will, the researchers will monitor a population over years and sometimes decades. So the associations between smoking cigarettes and the harmful effects like cancer and heart disease and bladder cancer and things along those lines, those were only those results took a long time to get and were only ascertainable because of these longitudinal studies that looked at these associations for such a long period of time. And these associations between like smoking and heart disease, they were so pervasive, they were so strong, and they looked at so many individuals over such a long period of time. Eventually they said, this is causal. This is not just an association. This looks like smoking causes cancer, certain types of cancer. Smoking causes heart disease. Maybe. Well, the problem with vaping and e-cigarettes is those studies have not been concluded yet. So they're still, they're still being examined, they're still looking, but they're not mature enough in order to make, if you will, these causal determinations. Vaping appears to be less harmful than smoking, but saying something is less, is safer than smoking is not saying much at all. That's really what this is saying. And smoking causes 1 in 5 U.S. deaths each year, and a huge cause of, if you will, premature death, morbidity, mortality, things along those lines. So using smoking as the benchmark is a crappy benchmark. E-cigarettes, so basically, nicotine-containing aerosols, so invented by China. I'm not picking on, the Chinese or anything along those lines, but U.S. patent application describe the e-cigarette device. I'm not going to read that to you, but you get the idea. Promoted as a healthier alternative to cigarettes. I believe I mentioned elsewhere in this presentation that even the British, they've talked about that. They've researched that. But they also, there's different restrictions that are out there. They don't basically say vape whenever you want type of deal. It's very, it's kind of a structured protocol, and there's been some success there. But I will tell you, in the main, what happens is people then become addicted to their vaping device. Trading one for the other, is one a little better than the other, perhaps. I don't know. So, assist in smoking cessation, maybe, maybe not. And you can pretty much at this juncture smoke them in a lot of places. I remember before COVID, I was at a meeting in our campus at Rutgers in Newark, and one of my colleagues, who's brilliant, he's brilliant as well as he's a brilliant statistician. He's a brilliant writer as well, prolific published. I've done the pleasure of working with him. But we're sitting in a meeting, and all of a sudden he pulls out his vaping device and this big plume, and it was just like, I remember in the days, 30 years ago when I worked for Prudential, 35 years ago when I worked for Prudential, smoking was allowed in buildings, but it's not anymore, so it's just this weird, phenomenon, that weird time that we're going through. Many places are really starting to say, no, you cannot do this inside, anymore. But it's still, there's places where you can. Where smoking cigarettes, no. So comparative study of tobacco, e-cigarettes, so you're really looking at, on the left-hand side, conventional cigarettes, on the right-hand side, the electronic cigarette, and you're really looking at, the top part of what are the components, the middle part of the smoke products. So, what you're seeing there in the middle part is greater than 4,000 chemicals in a regular traditional cigarette. Okay, in an electronic cigarette or vaping device, there's fewer substances, but it's not that there's none, number one. And number two, some of the chemical compounds are still not well understood. The health effects are not well understood. I will tell you, it doesn't mean we don't know anything about the effects of vaping. What we do know is that individuals who vape, particularly heavy vapors that vape substances that they've gotten, off the dark web or the black market or through some nefarious means, okay? Those are the ones that can get into some real trouble, that maybe present to our emergency room, end up in our ICUs on ventilators with things like popcorn lung. Okay, and individuals who've, the device itself has ignited and what's called plasticized their lungs, where they actually inhaled some of the plastic caught fire, if you will, ignited, and they inhaled it, and that stuff plasticized their lungs, and it's just a very, very bad place to be. Potentially fatal, you become like you need like a lung transplant sort of thing. So the substances that are from more recognized sources, okay, and the delivery device from more recognized sources, there's many fewer cases, if you will, of individuals having severe problems. It doesn't mean they're safe, okay? It does not mean they're safe. A lot of question marks with e-cigarettes and vaping device. That's the take home. Youth and e-cigarettes, so basically young individuals, it's using an exploding rate. Middle portion of this slide, went from about 4 to 5% to over 13% in 2013-14, and now it's approaching 20% for adolescent individuals. So tobacco industry aggressively marketing e-cigarettes to the youth, but again, some of that's been curbed. Glamorizing e-cigarettes use in advertisements, e-cigarettes, candy flavors, but again, some of that's really been limited deliberately because it was contributing to increased use. The online use has been restricted, but that's again a tougher thing to be able to regulate. E-cigarettes, so poisoning skyrocket among youth. Study finds that surge in e-cigarette exposure, again, mainly with young kids, especially dangerous to young kids who have lungs that are still forming. Imperfect solution to saving lives. Could vaping save millions? Still a question mark. My sister-in-law quit smoking cigarettes, and she vapes. And she vapes as much as she smoked, probably more, whatever. Now many of us know Dr. Scott Gottlieb, because we hear talk about COVID. He has a book that just came out. I think it's coming out actually next month, but he has some early release, marking some early release versions of it. But he was also, what's interesting, Dr. Gottlieb is an interesting guy, not just with the whole COVID thing, but when he was FDA commissioner for a little over 2 years, he was first a fan, and he came out. He's a very, very smart guy. Came out and said, I think that this holds potential to help people quit smoking. And he basically did a 180 after about a year, and he just basically said, there's too many unknowns. And I really kind of respect it, because he didn't do it behind the scenes. He came out and said, I'm doing a 180. I initially thought there might be something here, and there's more information that's materializing, and it looks like there's too many unknowns. I initially was saying there might be something here. I would steer clear of this for now until we know more. So it's just kind of he's an interesting man, very, very bright, and kind of has shed light on a lot of things that even transcend, some of the recent things with COVID. So more effort and research are needed. And you're looking at, while e-cigarette aerosol doesn't include all the contaminants, it still isn't safe. And, some of the specifics in this slide, looking at most e-cigarettes deliver nicotine. So hence, we've included it in this presentation. Highly addictive, can harm developing, brains of teens, etc. In addition, nicotine e-cigarette vapor could include potentially other harmful constituents, particularly if the substance being vapor or the vaping device, it's just been gotten through some, as I said before, nefarious means. Heavy metals, nickel, cadmium, tin, lead, no bueno. Those are all substances that can stay in your body and can cause a lot of bad effects, including cancer, including brain damage. Liquid used in e-cigarettes can be dangerous, even apart from its intended use. Children and adults have been poisoned, swallowing, breathing, being effective, even absorbing the liquid through their skin. And again, the e-cigarettes have been linked to thousands of cases of serious lung injury. Again, in most cases, substances or devices gotten through, nefarious means, but not all the cases. Sometimes it's been a reaction that the individual's body, they had a reaction to the propylene glycol, and it was some sort of allergic reaction or other sort of chemical reaction. So it didn't necessarily involve, the device or substance that was gotten from the dark web, let's say. More work needs to be done. Surgeon General has called the e-cigarette use among young people a public health concern. I would say among people. And again, some of the measures that have been taken, including e-cigarettes and smoke-free laws, regulating the tax on e-cigarettes the same way tobacco products, removing the flavorings. So you can see we have enforcing laws that raise the minimum age from 18 to 21. American Heart Association supports maintaining that the FDA's regulatory authority over e-cigarettes, just like they maintain authority over tobacco products. Now, conventional cigarette. Not in any way to dismiss, the importance of reviewing vaping, but smoking conventional cigarettes is still an issue. We see, nationwide, we've seen over the past 4 decades, we've seen a significant decrease in the prevalence of smoking amongst adults in the United States. So now it's about 20%. Going back 4 to 5 decades, it was closer to about 45%. In New Jersey, and again, I know we have individuals from throughout the country. In New Jersey, it's about 15%. Some of this is associated with some tobacco use, not so much vaping yet, but actual conventional cigarette usage is linked to socioeconomic status. I'm not making this up. So you have individuals who make more money, tend to smoke less. Individuals who make less money tend to smoke more. I'm just Throwing it out there. I'm not saying it's causal. I'm saying it's an association. It's the #1 preventable cause of morbidity and mortality in the United States. I would argue worldwide. Okay, and you can see some figures in the subsequent bullet. 443 deaths per year, United States, a big burden on our healthcare system. Causality established for many cancers, cardiovascular, lung disease. We know about lung cancer, but also even things like bladder cancer, where you think, someone's smoking cigarettes repeatedly, it gets in the constituents get in their saliva, they swallow saliva, goes through their digestive system and ends up in their bladder. So things like intestinal, colon, and bladder cancers, there was an association there as well, in addition to lung cancer. Primary etiology of COPD is exposure to tobacco smoke. Only known method to prevent or slow the progression of COPD is to stop smoking. And it's disproportionate, if you will, prevalence of smoking in the Medicaid. And Medicaid is for mainly for indigent and disabled individuals. So you get individuals of a lower socioeconomic means. Granted, Obamacare did expand the eligibility, so it's not entirely that way. But again, in the main, individuals who are on Medicaid tend to make a lot less than individuals who are not on Medicaid. That's the only point there. Is it ever too late to quit? So I should have said this earlier on in the presentation, but I smoked. I'm embarrassed to say, but it is what it is. You can't change what you did wrong. So I quit now. It's a little over 15 years ago. So I can attest to some of these. Some of these I actually experienced. Some of these I didn't. So everybody's different. But what they're saying here is not about me. It is about individuals who, who quit smoking overall. When they polled them, they found that these were some common themes that were found. By the way, quitting smoking was one of the most humbling experiences of my life. Okay, so I've had a lot of humbling experiences in my life, and this was certainly one of them. So anyhow, back to the presentation. After 1 day without smoking, blood circulation improves. It really has to do with you haven't reversed some deep physiologic phenomenon. What you've done is you've taken nicotine out of the equation. Nicotine causes, among other things, vasoconstriction. So you take that out of the equation, and you have, basically vasodilation, not because you're dilating the vessels, because you're removing the vasoconstriction. Carbon monoxide levels drop. So if you were to do a carboxyhemoglobin level on an individual that just had 2 or 3 cigarettes, you'd find that it's probably in that 6 to 10% range. Okay, whereas if individuals who live in remote, unpolluted part of the world, it's near 0. For those who live in the inner city, it's maybe 2 or 3%. And don't smoke, no one has it. But in smokers, it can be as high as 10%, particularly if they've just had 1 or 2 cigarettes. Heart rate and blood pressure drop because, again, you're taking nicotine out of the equation, and your heart attack risk drop, not because you've made the heart healthier, but because you've removed the coronary artery vasoconstriction that can result from smoking. So it's not just constricting systemic vessels, but also specifically those cardiac vessels. And so you have some of these benefits that happen just by removing nicotine from the equation. Likewise, within a few days of quitting, smell and taste can improve. A pulmonary function test can increase. It's not, again, because you've reversed lung damage. Not. It's you've taken an irritant out of the equation. So whether it's actually nicotine or just the smoke itself and all the constituents of that smoke. And because, again, if they're irritating, you've taken the irritant out of the equation, breathing can become easier as well. Long-term benefits or longer-term benefits, decreased rate of heart disease, risk drops by about a half after 1 year. So none of this is simple, but if you were to kind of overly simplify it, you'd say that the cardiac risks drop more precipitously, quicker than the risks of cancer. Okay, so your decreased risk of heart disease drops pretty good in a year. It doesn't drop in the normal. It's not like you're a baseline type of deal, but it drops much more quickly. Decreased risk of lung cancer, eventually approaching that of a non-smoker. 15 years, although I still work at a major medical center in north central New Jersey, and I just treated a guy yesterday who quit in 2011, and he had a video-assisted thoracotomy, and they removed one. He had a pneumonectomy. I'm not saying, but the guy that did it, the VATS surgeon, the thoracic surgeon that did it, he says, you don't take him literally, but what he says, if you don't want to get lung cancer, don't smoke. Now, again, don't take him literally, but he basically says that about 95% of the patients that he removes malignant lung tumors from smoked. Okay, so I have a significant smoking history. Decreased risk of other cancers. I alluded to some of this before: mouth and esophagus, bladder, intestinal, colon. I didn't mention it all here. Pancreatic cancer, there is an association there as well. A decreased risk of COPD. And then beyond that, if you stop smoking, the reduction in the progression of it, okay? That we all lose, whether you smoke or not, we all lose about 1% of our lung function for each year beyond about age 40. Again, that's a crude guideline, all right? So you're gonna lose some of your lung function irrespective. What they're saying is, you stop smoking, you take the component of loss of lung function associated with smoking, you take that part of it out of the equation. So the COPD does not progress as it would if the individual kept smoking. Other health benefits: lower risk of cataracts, hearing loss, erectile dysfunction, dementia, and other abnormalities. Even if you already suffer some smoking-related illness, still benefits there. So reduced risk of a second, third heart attack, risk of subsequent stroke is reduced, progression of COPD is reduced, increased chance of recovery from some of the disorders that we talked about as well. Now let's talk about some of the evidence-based guidelines that are out there. So you're looking at, there's one that relates specifically to treating tobacco use and dependence, and really the framework that the intervention, the CDC's clinical practice guideline is operated through, or the lens that you can kind of view it through, requires a repeated intervention. So it's not something that you just do one little thing. Oh yeah, take this pill or go to this meeting, get hypnotized. Some people, by the way, get hypnotized once and they quit, and that's it forever. Most people do not fall into that category. Most people, it takes 5 to 7 attempts to quit smoking. Effective treatment exists. I like to look at it this way, and there's some literature. It's not just in my brain. Okay, is that there's things that individuals can do to enhance their chances of eventually being successful in quitting. By the way, one of them is to continue to try, even if previously unsuccessful. It really speaks to that preceding bullet point of multiple attempts, 5 to 7 attempts for success. Doesn't mean you can't. I was successful. Praise the Lord, I was successful in my first attempt, but yeah, call it luck, call it whatever. I don't know what you call it, but again, it was very difficult for me to do for over the first year. It was difficult. Effective treatments exist, so you kind of things that you can do, each one of which crudely may increase your chances of success by 5%. So it's not like there's no panacea, there's no magic bullet out there for the most part, for most of us. But there's, if you combine certain things, behavioral things, maybe some medication, changing your pattern, support groups, helplines, quit lines, then maybe you turn you can increase your chances by 20, 25, 30, 35%. And certainly if you combine that with multiple quit attempts, you can really enhance your chances of a successful quit attempt. Treatment significantly increase the rates of long-term abstinence. Again, combining them may even further synergize that. Clinicians should offer brief interventions. So what we also know now is that even if, so I'll talk about this in subsequent slides, but that even if the intervention is structured but short, 3 to 5 minutes, okay, to enhance the individual's awareness of what's out there and how they may be able to benefit from it, okay, can be very useful. We didn't know this 15, 20 years ago. We now know it. So CMS is the Centers for Medicare Medicaid Services combined with the Joint Commission. So CMS gives the Joint Commission some statutory authority. So they kind of work together on some initiatives. Some of the tobacco use intervention, if you will, program recommendations were the result of these joint efforts. So again, this peer review organization of hospital quality care, the standard in yellow here is smoking cessation advice or counseling is required to be given to admitted patients identified as smokers. There's a few subgroups that may not apply to, including individuals who have severe psychiatric disorders. But for the most part, a smoker is someone who smoked a cigarette in the past year. If I saw that definition when I was trying to quit smoking, would not have been helpful to me. So this is a okay operational definition for CMS. That's fine. But one of the things that I had that helped me out the most was when I had quit for a month, I knew that if I picked up a cigarette, I would be back to day one. I wouldn't be on day 30 or 31. Okay, I would be back to day one. And I was like, I don't want to be back there. I made it a month. A long way to go, but I made it my month type of deal. So if I was still considered a smoker, I'd be like, I might as well just go back and go and smoke. So all I'm saying is it's fine for an operational definition for CMS Joint Commission. Might not be fine to tell our candidates who are trying to quit smoking, our patients, our friends, et cetera, trying to quit smoking that, oh, you're still technically a smoker. Nah, I would hold on to that. Inpatient tobacco use and dependence program measures some of the measures. So tobacco. So what do we mean by that? Okay, that yellow, that statement, it was in the yellow for the preceding slide. Tobacco use screening needs to take place. And then tobacco use treatment provided or offered during the hospital stay. Tobacco use, et cetera, the treatment provided or offered at discharge. Okay. So you get things like a nicotine patch, and you get, some resources, and you get to speak to, somebody professional, okay, about your tobacco use while you're in the hospital. Okay. You get a similar, sort of regimen and discharge. All right. And then you get this follow-up. How did we do, post discharge? And then you have these actual 6 steps to the hospital-based design tobacco treatment program. Identify tobacco use on admission. So this is really more on the clinician to patient basis. Okay. Identify tobacco use on admission. Assess the readiness to quit the stage of change, and we'll talk about that subsequently. To assess the level of dependency. To offer and facilitate practical counseling. To recommend or require the medication order. Okay, if medications are deemed to be potentially helpful, which many times they are, and then the post-discharge follow-up. How you doing? And if you did relapse, it's not a punitive thing. It's what can we do to get you back, to get you back on a wagon here. Okay. And again, looking a little more in detail at the stage of change, you get at least 6. And again, could you be in between? Could you revert from, could you go backwards a little bit? Sure. But for all intents and purposes, 6 stages of readiness for self-change are identified in the context of quitting smoking. Pre-contemplation, not even on the radar screen. Contemplation, I'm thinking about it, but I talked to this guy, but I'm busy. I got a lot of things going on. I got COVID. I got this, whatever. Preparation is now you're saying, look, I'm still thinking, but now I'm whatever. January 1st, my birthday, my holiday, whatever. The action is not using tobacco. You think about it for a minute. Okay. Many things in life are not easy, but they're simple. Okay. So this is one of them. So quitting smoking is not using tobacco. Okay. Or quitting vaping is not using your vaping device, but it's the action. So it really is simple. Don't use it. Don't smoke. Don't vape. Actual doing it is not easy though. It's simple. It's not easy. You're not solving the benzene ring theory. You're not giving this test, that really hard test. You just don't smoke. Don't do something. Don't smoke. Okay. But actually actualizing it is the hard part. Okay. So the action is not using tobacco. The maintenance is remaining tobacco free. Okay. Lapse and relapse, if the individual does use tobacco or vaping devices, they're trying to quit vaping, is that there's a plan to try again. Doesn't mean you got to, smoke away, not saying you got to do it this second. If you got to go out and buy a pack of cigarettes, a vaping device, whatever the case may be, to get through today and tomorrow, you got to do what you got to do. But don't let that be the long-term plan. That's just that's just because you got to kind of get back on a horse again, or get back on a bicycle, and get with the program. And then the actual, if you will, tobacco dependency assessment, these 8 elements. So really, so now you're actually, well, what kinds of things, when you're talking to a patient, what kinds of things do you want to really know? It's, it's this kind of like, well, the heavy smoker, the medium smokers, have they tried before, whatever. So it's really looking at previous and present tobacco use. The catch to that is this, is that any of you that have interviewed a COPD who smokes, okay, many of them lie, okay, they lie. They're like, How much you smoke? Oh, I smoke half a pack. And the wife's in the background or the husband's in the background saying, holding up like 1.5 fingers. Nah, it's really more like one. It's like one. Plus the patient reeks. Or did you quit? Yeah, I quit. I had one earlier today, but I kind of quit. Yeah. Meanwhile, they reek. Their clothing reeks of it, type of deal. So it's previous, present tobacco use. I'm not saying you need to hook them up to a lie detector test, hook the electrodes up to their head. No. But I'm just saying, just try to get is that okay? That's it. And if the wife's saying something different, then, don't embarrass anybody, but just try to get to, the real deal. That way it's going to be more helpful in helping the patient help themselves to quit smoking. Previous quit attempts, how many, how did they go, what happened, why weren't they successful, what was happening when you relapsed. Previous withdrawal abstinence symptoms. And again, the Fagerström test for nicotine dependence, we'll talk about that, as well as the Kessler-6. Some of the medical history, assessing some of the triggers, when do you have your first cigarette, et cetera. Some of the actual, the assessment tools that the Fagerström and the Kessler talk about, these triggers, when you have your first cigarette, after you wake up, et cetera. Optional CO is not cardiac output, it's carbon monoxide level. That's really something that's not commonly done. Obviously, you need some form of co-oximetry. Proceeding ahead with practical counseling if it deemed that it may be helpful. So the Fagerström test for nicotine dependence. It's a very easy, short, if you will, tool, 6-item measure of physical dependency, validated with biochemical indices of smoking. So what they're saying here is this. They're saying that it is valid, it is accurate in assessing physical dependency, and they've done it by if you will, drawing blood and looking at indices of smoking and looking at co-oximetry sort of thing. So important for the choice of medication dosages. Are you going to use medication at all? And the goal is to prevent. I don't know if you're going to prevent withdrawal symptoms, but to minimize or mitigate them is a realistic goal. And the score, when I teach students, it's always important to kind of know is high good, is high bad, is low good, low bad. So in this particular case, when I say high is bad, in that it's associated with someone who's more highly dependent on nicotine. That doesn't make them a bad person. Okay. So moderate is middle of the scale, around a 5. And if you're less than a 5, it's a lower dependence. It may be more behavioral than physical, more behavioral. And this is just an excerpt of what it actually, what the actual scale looks like, etc. Effects of vaping and e-cigarettes on cessation of conventional cigarettes. Now I talked about one, I was talking about the other. Now it's a little bit of the overlap between them. So there's many unknowns. That e-cigarettes are promoted as smoking cessation aids, possibly better than nicotine replacement therapy. So NRTs, we'll talk more about that in a few slides. Adkison, et cetera, International Tobacco Control Study. So look at current smokers. Significant. So vaping, significant reduction in the number of cigarettes smoked each day. So vaping resulted in that, but did not help individuals totally quit. Okay, this is one study. Doesn't mean it's everybody, but it resulted in reduction in cigarettes. It kind of makes sense because people were substituting one for the other. All right, but didn't affect quitting. So some of them ended up, I do both. And I smoke fewer cigarettes, but now I just do both. Vickman and others, 67% of all smokers use e-cigarettes to quit. So basically with some limitation there, and also inferred that e-cigarettes were not a good tool to quit with this study. So it was mixed results. To quit, that was the key. The endpoint was, did you quit? One of the major endpoints, I should say. Researchers from the UK and New Zealand reviewed over 660 current smokers. And they determined that, researchers looked at the effects of e-cigarettes. They were able to reduce the number of cigarettes they smoked by at least 50%. Okay, so a lot of this, the central theme here is may be very helpful in reducing the number of cigarettes, in some cases very significantly, but more work is needed. Not necessarily in quitting smoking, and this really needs to be reviewed more, just as we said in the earlier portion of the presentation. So now let's look at the medications. Okay, so first line medications, nicotine and non-nicotine. So nicotine patch, gum, lozenge, inhale, nasal spray. But many individuals, it's the patch, gum, maybe the lozenge, and less commonly the inhaler and nasal spray. But they're out there. They're out there. And then non-nicotine is bupropion, and the other one is Chantix. Okay, bupropion is basically Wellbutrin. So it's a selective serotonin reuptake inhibitor, an antidepressant. Okay, we'll talk more about that. Med use doubles or triples success rate, just to be clear on that. And it may not be a perfect, it may be the first regimen wasn't totally successful, but then when it was tweaked and a subsequent attempt, it seemed to work well. Counseling plus meds, even more evidence for success. So Chantix is an antagonist and partial agonist. Okay, so let me just, I'm going to come to that second major bullet. Let me just skip down for a minute here. So it's an antagonist. Think about when you guys took, for respiratory therapists, nurses, you guys probably learned this as well. But we talk about what makes certain medications work. What makes them is that they're an antagonist. They block, if you will, receptor sites. So they block, in the case of some of your bronchodilators, some of them act because they actually will block receptor sites that otherwise would cause bronchoconstriction. But that's not what we're talking about here. What happens is Chantix will block receptor sites that would otherwise cause nicotine to make the patient feel good. So what happens is they're taking Chantix, and we'll talk more about it, but taking Chantix, they smoke, they do. They don't get that, they don't get the euphoria, they don't get the benefit, okay? It's also an agonist in that it emulates, it partially activates the nicotine receptors. So it gives them some of that feel good, activates the nicotine receptors without the smoking. So it blocks the effects of smoking, but gives some of that benefit. So just coming back to the top bullet there, talking about it's an agonist and antagonist and partial agonist. That's what we mean. Okay, that's what we mean. The second bullet here is it's selective, again, just giving the receptor sites alpha-4 and beta-2 nicotinic acetylcholine receptors. Fancy words, guys. It's fine. But for the sake of completeness, you know what it is. But basically what it's doing is blocking the effects that the person would otherwise feel from smoking, the euphoric or whatever, feel good. And it's giving them some of that without the smoking part. So dosage, you start the med in advance. You think about it. If you want to try to, emulate that feel good and start to block those receptor sites, you're starting at about a week before the quit smoking date. So you're looking at 2 milligrams BID. And then for the first month, you're splitting up. So 0.5 milligram once a day for 3 days, and you're ramping upward. Okay. And it can be continued for up to 6 months. Precautions, I have actually 2 slides on precautions. This was one I've always had in, and then I've recently added a slide. Basically, precautions of Chantix: nausea, take it with food, headache, insomnia, abnormal dreams. What I'll say about the precautions on the right-hand side is that Chantix has been associated with exacerbating depression, agitation, and mood disorders, okay? And it has been associated with a higher rate of suicide ideation. So just thinking about it, and actual suicide itself, okay? So what happened was in 2008, the FDA put a warning. It basically said individuals should be screened for more severe forms of psychiatric illness, particularly depression, before they go on, and monitored very carefully when they're on Chantix. Is this happening? Are you feeling more depressed? Are you feeling in any way suicidal, or things along those lines? More recently, and really initial reports were in the spring of 2021, but Pfizer recalled Chantix. They recalled batches of it, because there were batches of it that contained a cancer-causing chemical, nitrosamines. They basically develop naturally, but when in higher amounts, if you will, they can be problematic and associated with cancer. So there was 12 lots of Chantix that were recalled. It's a Pfizer drug, as we said earlier there. Just wanted to put that in there I'm not anti-Chantix, by the way. It's just something you just need to consider, that number one, ensuring that, if you or a loved one or a patient are, being recommended to have Chantix, that they're aware that this recall has happened, They're also aware of some of the other potential effects as well, the neuropsychological effects. Zyban or Bupropion and Wellbutrin, I mentioned before, it's an SSRI, selective serotonin reuptake inhibitor. A little more. So, basically what it does is it inhibits the reuptake. So the body will reabsorb, if you will, dopamine. Well, it allows that dopamine to hang around. It allows it to linger at the brain receptor for the pleasure reward pathway. All right, that's the way that it works. And what they found was individuals, it was kind of a coincidence. They found that individuals were having an easier time quitting smoking, and they were looking at these large studies, and they looked at what medications are you on, and they just saw, these statisticians saw that there's association. More of these individuals are on Wellbutrin. The group that happened to be on Wellbutrin for, let's say, depression, that they are having an easier time quitting that. This was over a long period of time that this was investigated, and then they started conducting clinical trials and determined that yes, indeed, where there was smoke, there was fire, in a good respect. I'll tell you that I was quit for several months, and I've kind of felt I didn't relapse, but I really felt like I still wanted a cigarette. I was like, I feel the same way. Initially, I felt 3 months in, I still want a cigarette more. In some ways, I'm like, I don't know. It was a tough time. I went to my primary care physician, and I went on Wellbutrin for like 2 or 3 months. I don't know if it didn't hurt. I will tell you that much. It didn't hurt. I don't know if it helped, but I managed with some difficulty to make it through. So, patient on Zyban, no need to use tobacco or nicotine to activate the receptor pathway to release the dopamine type of deal. So it gives you that feeling as well. A little bit on the dosage. So it's another one of these medications, different medication, but another one of the medications that started in advance of the quit date, in this case, 1 to 2 weeks, starting on a 150 milligram dose, and then eventually ramped up to 300 milligrams. And then up to 6 months, I've heard of individuals safely being on it even longer, but they're saying in general, recommend 7 to 12 weeks to kind of get jump started, up to 6 months type of deal. Most common side effects, insomnia, dry mouth, pretty much relatively benign drug. Now we'll look at nicotine replacement, and just a couple points, because to dispel perhaps a couple of points that are, if you will, misconstrued aspects. So nicotine replacement therapy use is not an independent risk factor for acute MI, for acute heart attack. All right. It's not contraindicated for general cardiovascular disease patients. It is if it's within a close proximity, 2 weeks of a post-MI, serious dysrhythmias, unstable angina, any sort of allergies, nicotine or anything along those lines. So there are some clear, the restrictions that are out there. But what the individual should not do is, it's recommended that if they have the patch on and they want to smoke, they really should, number one, take the patch off. They should wipe the site clean, and they should wait at least an hour, okay, before because think about this. You got vasoconstriction from the patch, you got vasoconstriction from the cigarette. That might predispose the individual to a higher risk of MI. So looking at some of the, the other, general guidelines for nicotine replacement. So again, insomnia is a common side effect. Precautions for use in pregnancy, patch, gum. So it's really something you need to evaluate on an individual basis, but generally not recommended for pregnant women. But again, reviewed on a case-by-case basis. Not evaluated for safety. The lozenge has not been evaluated for safety, in particular with pregnancy. Most common mistake, broadly speaking, is underdosing. It comes in 7, 14, and 21 milligrams. And looking at, some of the ways of delivering it, the gum, a little bit of granularity here. So if, you kind of screening the patient, if the patient smokes less than 25 cigarettes a day, there's 25 cigarettes in a pack. So roughly a little, if they smoke a little, less than a little over a pack, then they would be started on the 2 milligrams. If it's greater than that, they're started on the 4 milligrams. And they're, one piece every 2 to 3 hours. They actually say, you don't just chew it like a regular piece of gum. You a couple bites into it, and you put it in between your gums and your lip. The lozenge, so I'm not going to bore you with all these gory details, but a little, similar regimen for the lozenge as well. The patch, as I said before, 21, 14, and 7. Minimum period is 8 weeks, and some of the prescribing instructions are out there as well, kind of recommended where you actually put it. May remove before sleep if there's insomniac, any insomnia, or if the patient has a history of being an insomniac. And then, as I said before, if the patient has really senses they're going to go back to smoking like imminently, within minutes or hours, they really need to wait, take the patch off, wipe it down, and wait a good hour. Combination therapies coming down a kind of home stretch here, nicotine replacement and bupropion. So really taking it, to almost, a 30% chance of quitting. The triple combination, even a little bit higher than that, and then nicotine replacement and Chantix. Only looking at that for like the first week, as you think about the way that the mechanism of action for Chantix as well. And then there is this, while you can get synergistic effects on a positive end of things, you can get synergistic effects on the negative end. You can have higher rates of like side effects such as nausea, headaches, and insomnia. Now, I wanted to spend a minute, without totally laughing at me. So I mentioned earlier in this presentation that I am a reformed smoker. And the way that I quit, and don't laugh at me, is before, when I was still smoking, I would periodically, probably 3 or 4 times, I encountered people in my life that said, gee, you're a respiratory therapist, or you teach respiratory therapy, or you write on respiratory therapy, and you smoke. Okay. And it wasn't about, oh, how do you do it? It'd be like, you ever thought about quitting? Now, I got that a fair amount. Okay. But there were 3 or 4 times when individuals said, I said, listen, you need to try to see the Mad Russian. He calls himself the Mad Russian. Okay. Okay. It's Yefrem Shobinov. He was up in Braintree, Massachusetts, which is a suburb, sort of suburb of Boston. And but this guy's existence was brought to my attention. You should go see him. It worked for me. It worked for my husband. And I was just like, so when I met my wife, we were dating about, I don't know, 7 or 8 months. And she said, I'm going up to Braintree, Massachusetts. She was a smoker. Braintree, Massachusetts, and we're going to see the Mad Russian in February. You want to come? I'm like, yeah, sure, whatever. So we went up there on a Friday. We had a meeting. You schedule in advance. We knew where to go. We scheduled in advance. We went up on Friday afternoon, February. It was cold but beautiful. We honestly, when I say party, we went to dinner, had some drinks, smoked our brains out. Then the next day, we all woke up. We went to see this particular gentleman and his wife. Second floor of a kind of a modest looking building, and there's a garbage can. Please throw your cigarettes out here. Throw our cigarettes out. Went up there, and he puts the whammy on you. Okay, and you're thinking, what the heck is the whammy? This is supposed to be an evidence-based presentation. I can only share with you the evidence and my own experience as well. This guy's got a good track record, as good as any of the others, by the way, that I've shared with you today. So he gives this general session, talks about smoking. He talks about this. He talks about that he's had his fears in his life, his insecurities, etc. And then after talking to you in mass, he takes you to the back and he literally takes 2 fingers, puts it on your forehead, and gives you the whammy. And he goes, now I want you to feel like you don't want to smoke. And I looked at him and said, I still feel like I want to smoke. So he put a second whammy on me, and I felt like, all right, I don't know, I feel whatever. But one of the biggest things. So let me say this much: the Mad Russian has had a success rate that's nearly 40%. So it's not 100%. Let's be clear on this. But if you look at all of the others, okay, there's really no other, kind of first time, success that is 40%, right? And it was kind of like phenomenal. And he basically says, listen, before you smoke, call me. You can call me. You can call me, and I will talk to you. Okay. Don't call me if you smoked already, though. But he goes, I'm here for you. Long story short, put the whammy on my wife, put the whammy. We were up there with 6 people, the other people. We all drove home. Some of them either smoked on the way home or smoked, shortly thereafter. And I remember I still kind of felt like I had to smoke. So I don't know if it was totally effective on me, but I remember we left Boston a day early because there was a snowstorm. So we drove home with a snowstorm. So what's called a backdoor front. It was actually right on our asses. This snowstorm was following us, like the way coming from Boston to New Jersey. And I remember my now wife, but my girlfriend at the time, was saying, I kind of want a cigarette. I'm like, hey, hon, we drove all the way up to Boston. We had a great time last night. Went to see the man. We kind of did a lot. Let's at least give this a shot. Okay. I remember saying, I feel like I want a cigarette too, but let's think about something. Let's talk about something else type of deal. And again, I was very blessed in that. So of the 6 of us that went up there, 3 of us remain quit, 3 of them relapsed. I don't know, by the way, we are not in contact with all of the other 3, so don't know if they eventually were successful. But interestingly enough, the 3 that were not successful initially smoked less, like they had less of an urge. They did report that. But in any event, all I'm saying is this: it's not about going to see the Mad Russian. It's not about that. Okay, it's not any of that. What it's about is I presented to you some of the evidence-based guidelines, okay, and evidence-based interventions. There are others, okay, and I am absolutely not anti-hypnosis, okay, and so I do know of people that on first attempt got hypnotized, quit, and never went back, okay. The theme is this, is that whether it's you and, you know, for your patients, you should be recommending evidence-based stuff, okay. So I'm not saying you recommend the Mad Russian or whatever, hypnosis, but for you and your loved ones, is you keep an open mind to things as they unfurl, okay, and aids that can be out there, because we know that smoking can be so harmful, and vaping may end up, you know, we may end up discovering it's as harmful as well. Is you need to keep an open mind, you need to continue to review the literature, and you need to continue to kind of stay up on, you know, whether it's through, you know, continuing education, your own research, going to conferences, whatever the case may be, stay as current as possible. Some of the resources that are out there include these: smokefree.gov, New Jersey quit line. Again, Jersey boy, by the way, New Jersey uses the New York quit line. So, I mean, it's you know, NJ stops, but we avail themselves of our services across the river there. So thank you, New York. Some selected references are listed here. And with that, I want to thank you guys very much again, whether you're first timers, or you've been to us before. I want to thank you for your patronage, and hopefully you come back to us. And again, we wish that you guys have a great day. Thank you.